We're sticking with our cardiovascular theme, and so I'm going to talk about cardiac and coronary CTA 2023, which is, of course, coming to an end very soon. I don't have any disclosures relative to this talk. And I think what we're all seeing is an increased use of coronary and cardiac CT in our practices. Even if you're not personally doing it, we're seeing increased involvement, increased volumes, and so forth. And it clearly has some advantages with respect to competing technologies. Obviously, it's anatomic. There's no invasiveness per se, and it has some cost advantages relative to MRI, which is also non-invasive. So if you look at different strategies, approaches, and this is just a complicated drawing, but if you look at the region of the curve, you can appreciate that the CT, a combination of starting with CT and then going to cath as needed, is perhaps the most cost-effective strategy. But it is true that to this day, there is a major competitor remains nuclear stress testing. And there are certainly many situations where that's appropriate. So that's by way of introduction. What I'm going to do is go through some of the technical aspects and then run through calcium scoring briefly, coronary CTA, coronary anomalies, and then some recent advances that I think are relevant and that we're actually in many cases using. Just the basics, of course. Our technologists, I think, have gotten very good at this, attaching the leads in the proper location, checking the tracing, making sure the R wave is triggering, looking for arrhythmias, and obviously if there are complications like, let's say, chest hair, making sure that that's taken care of. And there is arrhythmia adjustment software to mitigate any arrhythmias to a certain extent. And I'll come back to that in just a minute. The two major options that we have, remember with CT, coronary CT, we do ECG gating. And of course, the two major options are going to be retrospective, which is an axial acquisition throughout the cardiac cycle and leads therefore to a higher dose, but is also more complete in its acquisition. You can mitigate this somewhat by ramping down modulating the dose at times in the cardiac cycle, which you view as less important. For instance, since we know that most of coronary flow is during diastole, this would be during systole where you'd ramp it down. You can get a dose savings on the order of 40% by doing that. So in general, we will do this. The other major approach is prospective. And this is a step and shoot technique where the beam goes on and off. And it's turned on at the time you wish, which in general, if it's the coronaries, is going to be diastole. There are some exceptions to that as well. Doing this as compared to, and you can see based on the drawings, will reduce your dose on the order of 70 to 80%. And of course, dose is always a concern. So it would be our preference to do that. There are other approaches that can potentially even reduce dose further. For example, certain scanners, or one vendor in particular has what's called a flash mode, which can acquire within a single beat, and that would reduce the dose dramatically. But in general, this is going to be our choice, and we prefer prospective gating wherever possible because of the radiation dose reduction. If you need functional imaging for some reason, which is rare, to do an EF, you will have to do retrospective. If there's a significant arrhythmia, you will want to do retrospective. If the heart rate can't be reduced to a reasonable degree, so if you have a heart rate that consistently stays around 100, even if it's a sinus tachycardia, you may be in a situation where retrospective is your choice. And then finally, very large patients would be another situation where you're going to want to do retrospective. But in general, I would say about 70 to 80% of the patients we do are prospective. Let's turn to some of the actual applications here and talk a bit about calcium scoring. Of course, that's been around for quite some time. This should be used in patients who are asymptomatic as a risk stratifier. And it's generally going to be a middle-aged individual with a couple risk factors, more or less. The most common scoring system to this day is, as I think everybody's familiar with, is the Agatston score. It is not necessarily the most accurate in some ways, but it has the most robust data, and its accuracy is sufficient. It's a semi-automated approach. and basically any pixel over 130 Hounsfield unit is lighted up on the automated, that part is automated, and then you circle the appropriate areas, and essentially the scoring system is summated as I've listed below. So you get a certain number of points depending on the Hounsfield unit density, and that's what ultimately gives you your score. And here's an example of doing that, turning kind of lavender in this case in the LAD and circ, and then you'll end up with a certain score. You'll notice there are other scores there. There's a mass score, so there are other scores that exist. But the norming to this day is probably best done because of the large database is using the Agatston score, regardless of its limitations. And then, of course, you can use age, gender, other considerations, ethnicity, and so forth, and put it on a scale and therefore come up with a number where the patient falls on the chart. So in this case, the dot seems to be in the 85 to 90th percentile range. So that would be where you would want to, that's what you would report. There have been a number of revisions in terms of the indications for calcium scoring. So here are the common indications or the common criteria. So it's going to generally be somebody who's over the age of 40, has intermediate risk factors, and it's the asymptomatic population. And generally, as a rule, the calcium score is, if you have a 0 and you have a little suspicion beforehand, you might want to DC statins in that case. You're going to obviously downgrade the risk. And on the other hand, if you're above 100, and of course this is going to depend on age and where you fall in percentiles, you will tend to push for more aggressive intervention, including, and in the middle you might do things like diet modification. So those are some of the recommendations that are actually quite recent. All right, so I'm going to turn here to coronary CTA, and I'm going to mostly talk about a little bit about technique. I talked about it a bit the other day when we were talking about chest pain, and it's very much the same. So you essentially get your field of view scouted from around the carina down to the inferior margin of the heart. You can do it prospectively or retrospectively, as I said. We will generally, there are different ways to approach the pharmacology. We generally use metoprolol, although there are calcium channel blockers are an option. Generally, if the heart rate is above 70 to 75, we will definitely use beta blockers. Now, there are those people who feel like because of chronicity and regularity of rhythm, you should always use beta blockers. We actually do not do that. We only do it in patients with an elevated heart rate. We generally, depending on our practice is somewhat outpatient, somewhat inpatient, we generally will do IV. But if it's an outpatient, we may occasionally do oral as well. As far as nitroglycerin, there's been evidence showing that it there's evidence that it does somewhat improve results. Obviously, we look, and I didn't mention for beta blockers, but obviously the things to worry about are asthma and heart block. So we'll check for that. For nitroglycerin, we're going to check the blood pressure, and we're going to, you can use a spray. We do a sublingual tablet for any patient that isn't on Viagra and doesn't have diminished blood pressure. We have not found tachycardia, reflex tachycardia, be a problem. It's at least discussed in the literature. It has not been a problem for us. And this is one of the papers that shows that sublingual nitroglycerin substantially dilates the coronary arteries without diminishing image quality. So for the most part, it's a gimme, and we tend to do that. In terms of contrast administration, there are a couple of approaches. You can do a test bolus, which allows the image to be triggered when you get to a certain Hounsfield unit, or you can use a timing bolus. In this case, what we generally do, here's just an example of a timing bolus. What we generally do, though, is we essentially do a test bolus and we add 5 seconds. That's what we do with a trigger, which is usually a little bit higher than shown here, about 150. So that's what we do for our bolusing. And then in terms of the amount, we generally will do a full bore rapid infusion after the IV check and test bolus, which would be in this range, 60 cc's. We sometimes diminish it a little bit. And then we use a split bolus, 50-50 contrast and saline, and finally a saline flush. So our contrast bolus is on the order more or less of 75 cc's of iodine, basically. As far as the viewing options, there are a number of these, and I've listed them in this case in somewhat descending order. So we will often do volumetric imaging that comes up on the reconstruction. We have a map approach, curve planar and axial interactive is the other one. And so the curve planar, I think people who are well familiar with this, you essentially extract the coronaries in the appropriate plane. So you do the left main LAD, CIRC, and RCA, and you can get nice images. The interactive, this, in my view, is the most important. And this is, we essentially, depending on, again, your technology, you can use a swivel technique that a lot of, so I'll center it on whatever, and you can see me doing it here, whatever the structure is that I want to look at. This is actually a vein graft, and I'll swivel it around, looking through plane, in plane, and that's really the best way to get a true sense of what the level of stenosis is. There are other measurement tools. We actually rarely use these. These are in the interfaces that exist. In this case, I tend to just eyeball it actually and say I believe. You can take your own little handmade measurements, but here's MIPing it again would be an additional thing that you can try to do. And this is actually a paper that looked at that very question: which are the most useful reformats? And in fact, you can appreciate that that axial interactive one that I showed is probably the most useful, followed by some of the others. One of the things that I think is important in looking at coronaries is recognizing pitfalls. I mean, certainly measuring stenoses, as I mentioned, by interacting with the data set, you can do that very nicely. But pitfalls, what I tend to do with if it's mixed plaque or if there's any significant amount of calcification in this, I tend to underestimate that. I view that as I downgrade it. So you look at this and it looks like it's 100% stenotic in the in-plane view down in the middle there. But in fact, that's not true. It's an overestimation. And we'll talk about FFR in trying to sort this out in a little bit. But so I would tend to not say this is a CAD-RADS 5 or anything like that. I would say I would downgrade it to a 4A perhaps. And you can see that the nuke study shows there's actually no stenosis here. And it's, in terms of predictive value, coronary CTA does actually predict survival. So this is a study from a large conglomerate of the confirmed group, which looked at that very point. And you can see that there's a big difference between having at the bottom left main and going up the list, 3-vessel, 2-vessel. This is predictive of survival, actually, which is tells you it's a very powerful technique, unlike really many of the competing techniques. And this is apart from what's called the Scott-Hart trial, there's another trial called the PROMISE trial. This trial showed that as compared to standard care, meaning functional imaging, CTA was a better predictor of mortality. So it is the go-to approach for many, many patients, particularly those who aren't diabetic or elderly, who are going to have a lot of calcification, because that's where CCTA does not do as well. But in any other patient, generally, there's proof that at this point you've got a mortality benefit. And this has been recognized by some of the criteria. Now in the AHA criteria, it's equipoise right now. They'll say go either way. But these are the UK criteria, and they're actually recommending that CTA is a first line. And I think that's the direction we're going. All right, so I wanted to talk a little bit about other things in this run-through of coronary issues. And so I'm going to talk about bypass grafts and coronary stents. And that's a tale of two cities. Bypass grafts that are actually very well visualized. We can look at saphenous vein grafts, as I'm showing you here. This is from an article from some years ago, and you can see them very, very nicely, particularly the saphenous vein grafts. The lemma grafts are a little bit smaller, but you can see them too. The arrowhead there is pointing to a volumetric imaging version of one of those. And then we can also look for stenoses within the grafts. And we do very well, especially within the saphenous vein graft. And you can appreciate that in this case, there's a very complex mixed graft stenosis here, which is confirmed later on cath. And they went ahead and actually stented this. Another thing that you can see with a graft occlusion is what's called the Nubbin sign. And that's what I'm showing you here. So look at your aorta, look at grafts coming off the aorta, and you'll notice that in some cases you just have a little bit of a nubbin. That is generally going to be a sign of an occluded saphenous vein graft. And those are the ones that have a much higher rate of occlusion, so you're likely to see them. And this is just an example of a graft complication with an aneurysm. And that's much rarer, but this is a cabbage aneurysm. Now, in terms of the actual literature on this, it's actually quite favorable. It is said that maybe at the distal stenosis you have some issues, but that's generally not the case. So I find it to be quite effective. Stents are a different story. We are not, in general, doing stents as an indication. And this is why. You can see that stent evaluation, the largest stents we can see internally pretty well, but smaller stents are very difficult to see. So we know to recognize them, but we in general will not. They're not indications. And in fact, that's the way the literature rates them as well. We can see stent stenosis, and that is something that we run into from time to time. And the literature, again, supports this. If the diameter is, in the yellow down at the bottom, if the diameter is greater than 3 millimeters, we can, in fact, see that. All right, let's turn to another coronary issue, and that's going to be coronary anomalies. And this is actually very important. It's surprisingly frequent. It may cause all sorts of symptoms. It's the second leading cause of cardiac death in young athletes, secondary to hypertrophic cardiomyopathy. And we often see this incidentally. Our PE studies now have gotten so good that we often see it actually on PE studies. And cath is actually a poor study for this. There's a whole list of different anomalies. I'm just going to show you a couple of the ones that are probably the main ones, and recognize that the ones where the coronary comes off the wrong cusp are the ones that I think are worth focusing on. A lot of the other ones are either rare or just variants. But this is an example of one where the left coronary is going behind the aorta. You can appreciate it here. And this is a benign kind of coronary anomaly. We wouldn't worry about this one. Now, if we take a different example, now we have the right coronary coming off the left cusp and going between, in an intravascular course between the aorta and pulmonary artery. That is a malignant course. That's the sort that can lead to syncope, sudden death. And worse than that, very malignant, if you want to call it that, is the opposite. The left coronary, the widowmaker, going between the aorta and the pulmonary artery, as you can see in this case. So those are the coronary anomalies you're going to want to consider. There are other rare things like AVMs, Al Kappa, all sorts of other unusual ones, but we don't see that. So I wanted to take the last few minutes, that's sort of standard talk on coronaries, take the last few minutes and talk about a couple of recent advances that we are in fact using. And the first is CTFFR, and that is based on the fact that looking at CCTA in an anatomic sense doesn't get you any information functionally. And so one of the things you can do is, and then therefore, as in this case, you have to go on and get another study. One of the things that you can do is it mimics a catheter-based fractional flow reserve, which is basically the pressure difference across the coronary stenosis. And it's black box. The way that the data is done is kind of like AI in a way. We don't exactly know. But there are actually there's more than one version, although there is only one company that has an FDA approval. And so the way this works is essentially you'll send the data into the cloud to the people who reproduce it, the folks that have that, and they'll send you back a map. And this would be an example of that. So in this case, if you look, everything is blue. The aorta is sort of the standard, and everything is blue, or at least light blue, green. So these numbers are on the order of above 0.8 of the versus the aorta. So aorta is 1.8. That is basically a normal study. And you can see 0.93. Those are okay. And this is actually a case where they did a cath-based measurement. It was quite similar. This, on the other hand, is an abnormal. So if it's below 0.75, it's considered definitely abnormal. 0.75 to 0.8 is a gray zone. And then above 0.8 is, as I showed you, considered normal. This is 0.65, very abnormal. And we are tending to use this for stenoses in the 40 to 80% range. That, in other words, the case I showed you a while ago with the blooming, heavy calcification, that would be a case we would have used this for. And the takeaway, there have been quite a number of trials looking at this. It shows higher accuracy than standard CT, as is shown in the de facto study on the left. It also shows that it takes away the need for going to cath in many cases. You can see that in the platform trial, with usual care, you had to do cath a lot more than when you use the combined strategy of CTA and FFR. So that's very valuable. And this is just another study looking at the same thing. The ROC curve for FFR CT is the highest of any. See, it's competing with CT alone, SPECT, PET. So it's including all these functional techniques. Head to head, it does, quite well. And, so CT FFR we're using routinely in our clinical practice. And but not for acute chest pain, I should say, in our outpatient and standard practice. High-risk plaque is worth talking about too, because it is a component of CAD-RADS, which I'll talk about in a moment. Can we see high-risk plaque? The answer is to some degree. Classically, it's described as thin cap fibroblast which we cannot see. We can maybe see lipid core. Positive remodeling is one of the things we see pretty well. And what actually have been promoted as characteristic of high-risk plaque features are positive remodeling, as I just mentioned, low plaque density, which is that lipid plaque, and somewhat more controversially spotty calcification. If you have those features, and here's just a couple of examples of positive remodeling. You see the vessel wall has kind of expanded. Larger than, more distally than more proximally, it's actually larger with some complex plaque in there, a lot of low density plaque. Here's another one where the plaque mean density is below 30, which is often a cutoff that is used for that, for low density plaque, so high likelihood of lipid. This is a study which looked at these features that I mentioned, and they found it was predictive. If you had two of the features, 2 out of the 3, it was predictive for having an event, a cardiac event. So, so they had baseline and they looked later, and these features were predictive. So if you had 2 out of the 3, any 2. And then there's also another sign of what's considered high-risk plaque, and this is showing it. It's the napkin ring sign that's been described, was actually after some of that studies with a low attenuation surrounded by a high ring attenuation. And you can see a couple of NFOS examples there. And that's considered an independent risk factor. So these are features of high-risk plaque, and that would go into your thinking in terms of scoring your CAD-RADS. So let's talk about CAD-RADS 2. This came out, a group of us got together and talked it over, and came out last year. A lot of discussion, and I'm not going to, give you chapter and verse on this because it's a lot. But basically, as compared to the original CAD-RADS, which was some years earlier, the stenosis scale remains the same. So basically, where you're going to put that, where you're going to grade that is unchanged. What's been added is plaque burden and also ischemia detection. And this is FFR, or for the rare sites that do CT perfusion, you could use that as well. And basically, those 2 approaches include labeling the extent of plaque, P1 through P4, and whether there is or is not ischemia, or whether it's plus minus. As I mentioned, for FFR, there's that gray zone. So those are the features of that. The P score can be based on the coronary calcification score, the calcium score. It can be based on segmental assessment, which is the SIS, and it can be based on just a qualitative look. So this is an example of a P3 based on the calcium score, which is what we usually do, actually. Ischemia assessment, that's going to be based on either CT-FFR, and I mentioned previously some of the criteria, but you give it an I plus, I minus, or an I plus minus. And so this would be another example from our site where we've got an I plus, and you can see there's a 0.6 in there, clearly I plus, so we would grade it as such. In addition to that, the new system has modifiers. So there's a modifier E, and that stands for exceptions. So let's say your issue is not a stenosis, it's a coronary dissection, which is a rare thing, but anomalous coronaries, we did talk about that. That would be an E. A coronary aneurysm, which is also not all that uncommon. Many of these things are not all that common, but they would be labeled an E. So you could put an E in there to grade that. And then, in addition to that, in addition to the actual number score, the degree of stenosis, you would have these other modifiers. And so we put together an order system of how we would do this, and you can see high-risk plaque. That high-risk plaque used to be V, vulnerable plaque, but it's been recognized that high-risk plaque is a better terminology. And on down, and the second, third, and sixth modifiers are actually new. Those are the plaque, the ischemia score, and P, which is even higher. So I have just a quick example from the paper, which just shows an example of a CAD-RADS 2, which would be 25 to 50%, P2, which is based on the plaque measurement that I showed a moment ago, and the fact that there's positive remodeling, and that would be an HRP feature, high-risk plaque feature. So that would be how you would score it. It's gotten a little more complicated, but I think it brings into account some of these other things. And with each of these scores, CAD-RADS, there is actually a recommendation, similar to other RAD scores, like lung RADS, there's a recommendation, what to do. So for this, and there's actually, I put the acute chest pain, there's also a stable chest pain version of this. So you can say for 4A, in the acute setting, you'd want to consider hospital admission. So these are recommendations for what you might do. So each of these comes with a recommendation. And I think it's very important to mention, and this is also strongly mentioned within the document, that it has to be, it's a supplement. This is a tool to help, a tool to QA, a tool potentially for research, but it needs to be, it's not a standalone. And so I think it's very important to say, beyond that, here's your score, and here are the implications of that score. So I think that it cannot be left as a standalone. All right, so I'm going to finish off by just saying that calcium scoring is our risk stratifier in asymptomatic patients. Coronary CTA, symptomatic patients as a rule, which are well established for the various things I mentioned, assessing atherosclerosis, anomalies. Ischemia imaging and plaque imaging are newer areas that have now been incorporated into the latest version of CAD-RADS. And FFRCT, I think, is really growing in a great way, as is all coronary CTA. So with that, thank you very much. And as I always say, keep your cardiac antennas up. So.